Hello everyone, my name is Tandy Gabbert and I am the Director of Education for NAON. I will be the moderator for this session. Welcome to our June membership benefit webinar, Care of the Spine from the Surgeon's Perspective. The purpose of this webinar is to share perspective, evidence, and practices that lead to confidence, knowledge, and skills to provide care to the orthopedic patient who has a spine condition. Our presenter today, Dr. Sanjeev Suratwala, is an orthopedic spinal surgeon in New York. After completing his education in New York, he traveled to Minnesota for a spinal surgery fellowship. He subsequently was a recipient of the prestigious Cervical Spine Research Society Travel Fellowship, traveled to international spinal surgery centers in France, Germany, Switzerland, and the U.S. Dr. Suratwala has an interest in international healthcare and is a proponent of staff and patient education and a multidisciplinary approach to patient care. Dr. Suratwala, I'll let you take it from here. Thank you.
Thank you, Tandy. I was invited to give this presentation after presenting at the NAON conference at the AOS meeting in Orlando this year, and at that time a question was asked about what role a nurse plays in the in treating a spinal patient. So I decided to create this webinar to provide information to all the team members who take care of orthopedic and neurosurgery spine patients to have them share my perspective as a surgeon so that we all can collaborate better and provide better outcomes for our patients. I do not have any conflict of interest and nothing to disclose. The outcomes of this webinar are to provide information so that the participant can apply knowledge and skills to implement best practices in the care of the orthopedic patient who has a spine disorder. The objectives, we start with the basics like we do in medical school, which is understanding the base anatomy and basic abnormalities of the spine. After that, understand the treatment options available for the patient who comes to you with a spinal condition, and then understand the team approach to managing a spine patient and the critical role of the nurse in this care. And eventually, the goal is to provide a spine surgeon's perspective on care of the spine to the clinical team taking care of the patient, so that when somebody comes to my office or somebody has surgery, I expect that the care-taking team members, including the nursing staff, understand how I think about the patient, how I think about their problems, and how I anticipate that the patient's treatment will help with their recovery. My background was earlier cited by Tandy already, so I won't go through this. So the agenda for today's webinar is to start off with an overview of spinal disorders and anatomy of the spine, then move on to minimally invasive spinal surgery techniques, which are becoming more and more prevalent, and some of you who may have been doing this for a while may not be very familiar with what the latest treatment options available to patients are. Then maybe take a slight peek into the future, what direction surgical care of the spine is going, and then conclude with what the latest data shows regarding multidisciplinary approach to the spine. So let's start off with a poll question. What is your setting and what is the proportion of spine patients you care for? A, inpatient, more than half of my patients are spine patients. B, inpatient, less than half of my patients are spine patients. C, outpatient, more than half of my patients are spine patients. D, outpatient, less than half of my patients are spine patients. And E, none of the above.
Okay, 13% of people said A, 64% of people said B, 9% of people said C, and 14% of people said D.
Okay, sounds like most people, people on this webinar today are taking care of inpatients, with less than half of the patients being spine patients. So hopefully this information ahead will be educational. So let's start off with why we talk about the spine. Back pain and spinal ailments are fairly common. Most of these conditions are self-limiting, though, which is good. It's important to triage emergent conditions from non-emergent. It's very rare that you get a true spinal emergency involving acute or progressive neurologic deficits. So it's important to triage a patient and get a sense of, is this a chronic or an acute problem that will likely be resolved on its own, or is it something that is a neurologically compromised patient that might require urgent or emergent care? The internet, fortunately or unfortunately, provides easy access to abundant information, and I've done this in the past where I just put in back pain into Google, and you see that there are 164 million results in 0.15 seconds. So there's just tremendous amount of information out there, and it's difficult. This is what patients see when they go looking for information online, and I'm sure a lot of the clinical staff do something similar. We talked about anatomy earlier as the basis of our treatment. So what is present in the spine? So we start off with the skull at the top of the spinal column and the pelvis at the bottom, and in between them are the backbones of vertebrae. They're separated by the discs, which are commonly the source of problems with neck pain, back pain, radicular symptoms, sciatica, etc. The purpose of the spinal column very often is to protect the spinal cord, which is connecting with the brain to the rest of the body, and the spinal cord runs through the spinal column. So the bones and the vertebrae of the spine provide a very important function of protection of the spinal cord. They also allow muscles to attach and allow you to move around in space. And then, of course, the nerves that come out of the spinal cord and innervate the arms, legs, the trunk, the various parts of your body. So when you look at this abstract picture, you have to imagine, where is this problem coming from that might need surgical or non-surgical intervention. This is a slightly closer view of what we're dealing with. You can see that the vertebrae, the biggest portion of the vertebrae is anteriorly or in the front. In the back, you have the spinous process, which in thinner people you can actually just feel by running your fingers over your back. Separating the vertebrae are the intervertebral discs, which are the cartilage in the spine, and which very often wear out and lead to conditions like degenerative disc disease, or even herniations, where a piece of the disc extrudes out from between the vertebrae and goes into the spinal canal. Towards the back or posteriorly is the spinal cord. And you can see the individual nerves that come out at different levels, either on the left side or the right side. So the most common spinal problems that patients complain about are pain. Pain is by far the most common complaint that any patient will go to a doctor to see, either in the office or in the emergency room or urgent care facilities. It can be neck pain, it can be low back pain, it can be arm pain, it can be leg pain, which may be related to nerve compression. The other conditions that are less commonly seen, but most spinal surgeons will see in their practice, are deformity, which is curvatures of the neck or the back. You may have seen patients walking around with a hunched back, so that's a deformity of the spine. You may have also seen people with curved backs when you look at them from the front. This is scoliosis, and you see them in teenage patients as well as in the older patient population. And the third condition that patients will present with is neurologic deficit. It can be either weakness or numbness of the arms or legs. So we'll talk a little bit about neck pain and low back pain, since this is one of the most common conditions any clinician will see. It has typically a cyclical pattern. It varies in frequency and severity. And by this I mean that it's almost normal to have low back pain. There's an 80% lifetime prevalence. Almost every single person living today will have an episode of back pain in their life, and very often a lot of people may have had one episode of back pain over the past year even. And this is something that is self-limited, so it's considered more of a symptom rather than a disease in itself. And the peak incidence tends to be the most productive years of people's lives, between 35 and 55 years of age. So when you compare age at the bottom and then the incidence percent of back pain, you'll see that as you get older, the hash line shows the incidence of back pain, and almost 50% of people with at the age of 50 will have some back pain. But as you can see, as they get older, the back pain actually starts decreasing. The solid line actually shows the X-rays of the same people. So if you follow that down, you'll realize that as you get older, your X-rays keep getting worse, but your back pain actually does not correlate with that. And that brings us to a very important point, which is that the symptoms of back pain don't quite correlate with what we see on X-rays. Very often, patients will present with from their internist or from the chiropractor with X-ray saying that they have severe disc degeneration, and you look at the X-ray and you correlate that to the patient's activity, and the patient's playing tennis every day, they're swimming, they're running, so there's nothing really to be alarmed about that. So essentially, the point is that the correlation of X-rays with back pain is quite poor at times. The treatment when somebody presents with back pain is to use a combination of anti-inflammatory medications, decreasing the activity that actually causes the pain, and some rest, which is not really bed rest, but it's to limit your mobility. And as the pain subsides and goes down, you can get into remission. You start doing some exercises, which hopefully over time will keep you further and further in remission, and you have less severe back pain and less frequent back pain episodes. So again, the severity of back pain doesn't really correlate with the amount of disc degeneration. And it's very important to have a differential diagnosis. I cannot tell you how many cases of unrelated conditions I've diagnosed when somebody comes in with back pain, including peptic ulcer disease, diverticulitis, gallstones, renal stones. Occasionally you get pancreatic tumors, fibroid uterus, hemorrhagic ovarian cysts. So there are various conditions that can mimic back pain, and you have to really pay careful attention to the patient's history and physical exam to come up with a more effective diagnosis. In some cases, you also have to be aware of secondary gain, which may include drug-seeking behavior or people just trying to get out of work. Vascular abnormalities are also very important, including abdominal aortic aneurysm, and you have to be aware of their in the differential. So when somebody comes in with back pain, which is really coming from the spine, usually we categorize them into either preventive treatment options, conservative treatment options, or operative, which are the last resort. So prevention usually is, as you can be aware, it's exercise, weight control, avoiding tobacco products. Conservative treatment is the first line of treatment. Usually it involves medications like anti-inflammatory medications, muscle relaxants, and pain medications in for severe pain, but you have to be cautious with the use of opiates in this setting, especially when the pain persists for longer than 2 to 3 weeks duration. Physical therapy and alternative therapies may also be helpful in this setting. And operative treatment is usually the last resort option. It's meant for intractable pain that doesn't really resolve with any of the other treatment options, and for somebody who has pain for a very long duration. Operative treatment also becomes necessary when somebody has neurologic deficits. Here's something to also think about. There is no proven lasting benefit in low pain with epidural steroid injections, facet injections, manipulations, passive modalities, or traction. And these are actually very, very commonly used. So when somebody comes in with back pain, if you actually just gave them some rest and modified their activities and waited it out, the chances are that it would just resolve on its own regardless of what you did for them. So all these tend to be expensive options with no really long-term benefit to back pain relief. It might help the patient feel better that day or the next day, but as I mentioned earlier, if you simply did nothing for the patient, the odds are the pain will go away on its own. What about alternative treatments and complementary medicine? There's been a lot of literature recently looking at other treatment options, and acupuncture is very popular, something that I keep asked a lot in my practice in New York. And this is a study from Korea that they looked at chronic low back pain patients, and they actually did a sham treatment where the patient actually had needles that were put in, but they weren't the treatment type needles. So patients with chronic low back pain in Korea randomized to acupuncture versus sham treatment, and there was a significant difference in pain between the groups. And there was improvement with acupuncture using the traditional pressure points that they've studied over hundreds and thousands of years. Healthy lifestyle options, this falls into the prevention category, and certainly this is no one's idea of a healthy meal, but this is unfortunately one of the most common lunches or dinners out there in America. And to combat this, the U.S. government has come up with a My Pyramid. You may have seen versions of this in the past where it included the meats and the butter and the fats and the carbs in different categories in the pyramid. Here, the pyramid includes exercise, where you see on the left the cartoon climbing upstairs. At the bottom, grains, vegetables, fruits, milk, meat, and beans that get a slice of the pyramid. So there is moderation involved with everything here, and a balanced diet and exercise certainly is helpful to your spinal condition as well. Weight and low back pain, a lot of people ask about obesity and its correlation with low back pain. There's really no evidence that obesity in itself causes low back pain, but it does increase the risk. And over multiple studies, there have been a strong association with seeking care for low back pain. And the hypothesis is that if you do have a smaller injury, if you are obese, you're more likely to aggravate or inflame that area more, and more likely to actually experience the pain, whereas potentially a thinner person might not experience the same amount of pain. There are recommendations based by various organizations on physical activity and exercise. And again, very often people come in and say, well, I'm up on my feet all day, like a nurse, for example, and I stand on my feet, I'm going up and down stairs all day. That really is, that's considered being physically active, but it's not really exercising. And exercise has an added benefit to it where you work on your core and you perform non-impact aerobic activities, which have been independently shown to help back pain. And it has to be over a period of up to 12 weeks when you have an episode of pain. So this is not doing it once in a while and forgetting about it. It's a more committed program. And it works better if you're in a group supervised program where certainly being part of a group motivates people to exercise better and stick to the program. And this may include aerobic activity, which is non-impact, movement instruction, muscle strengthening, postural control, stretching, aquatic therapy. I certainly recommend a lot of yoga and Pilates to my patients, but with moderation to avoid things that would aggravate their pain. There's also been a strong correlation with smoking and low back pain. A lot of studies have looked at this in the past, and a meta-analysis, which is looking at a group of studies together, shows that both current and former smokers have a high prevalence and incidence of low back pain than people who have never smoked, but the association is fairly modest, and current smoking and incidence of low back pain is stronger in younger people than adults. So again, another incentive to get your patients to quit smoking. People who smoke tend to respond less well to any treatment options you might prescribe them, including medications, injection, or even surgery. And they have higher risks of infection, non-healing any spinal fusion, etc. if they smoke at the same time. So here's the next poll question. How comfortable do you feel managing a surgical spine patient? A, very comfortable. B, comfortable. C, not comfortable. And D, very uncomfortable.
.46% of people said very comfortable, 41% of people said comfortable, 11% of people said not comfortable, and 2% of people said very uncomfortable.
All right, great. So sounds like the vast majority of people here are comfortable or very comfortable managing the surgical spine patient. And hopefully by the end of this, even the people who feel not comfortable or very uncomfortable will feel more comfortable managing these patients. I think the difficulty very often is not knowing what happens in surgery of the spine. And in my practice, I try and encourage all my staff to come to surgery if they're permitted to come into the OR, also to attend conferences that we organize for them so they can do hands-on work and get a feel for the instruments and tools that we use in surgery and look at the x-rays so you get a better feel for the patients you're treating. I encourage you to look around in your communities to see if there are any courses or lectures being offered by your community surgeons, and you might find that very educational if you're doing some hands-on work. So the next topic of just as a background is deformity, and this is something that's less common unless you're very in a specialized practice, because this is best handled in a high-volume specialty group. So scoliosis is something that may be common to a lot of people, either through treating patients or you may know somebody who has had scoliosis. It's not just when you look at it from the front, you can see obviously the spine is curving towards one side, either the left or the right, but it's more than that. It's a complex three-dimensional twisting of the spine. So it's not just bending, but there's also rotation involved. And there are several types. Younger patients can get congenital, meaning that there are birth defects during development, musculoskeletal, which could be due to other conditions of the nerves and muscles. People get muscular dystrophies that can cause deformities. And it can be adolescent idiopathic, meaning that we don't know why it's there, and this is one of the more common conditions which most people will end up seeing. It's usually in the teenage girl population. And then the second peak of this is in the older patients, which can occur with degenerative conditions of the spine, essentially with arthritis. And treatment depends on the type of the curve, the age of the patient, whether they're skeletally mature, whether they're adults or they're still children. Also with progression of deformity, is it something that's getting worse rapidly or it's something that's stable in whatever measurement curve that you have. And then it's associated with any neurologic deficits, which obviously makes it something urgent in treatment. So typically, we still recommend bracing, which is as a first line of treatment for adolescent idiopathic scoliosis, meaning the teenage curves that we would see between 25 degrees and 40 degrees, and in the immature spine, meaning that the spine is still growing. And surgery is usually indicated for a spine that is still growing, but it has a curve that's bigger than 40 degrees. If it's somebody who's older and the curve is bigger than 50 degrees, so these numbers are important. Not everybody who walks in with scoliosis needs surgery unless they meet these criteria. If you have congenital or neuromuscular scoliosis, there's a much higher chance that the curve is going to keep getting worse and you need to stabilize it as soon as possible, or obviously if the curve is getting worse with progressive scoliosis over time. So that's just a very brief introduction to scoliosis. You could have a webinar on that by itself. Here's another condition that's actually a little more common, spondylolisthesis, which essentially means there's a non-alignment of one vertebra on another. And you can see on this x-ray, this is a lateral x-ray, which is a side view of the spine at the lumbosacral junction, which is at the bottom of the spine. You can see how this bone, the L5, is toppled over the S1, while the remaining bones maintain their alignment. So this is a fairly significant spondylolisthesis. And this is associated with a fracture of the spine, either traumatic or very often it's a stress fracture, which gradually keeps getting worse. The spondylolisthesis can be seen in up to 3 to 5% of the U.S. population. And most of it is degenerative that you get with age, but there's also a big component of stress fractures that people get in the teenage years, and over time it gets worse. How do you treat this? Very often, again, like most spinal conditions, it's treated conservatively without surgery. Bracing and activity modification is helpful for somebody with a traumatic injury or acute pain of a stress fracture. Surgery is indicated otherwise for intractable pain, or if the curve is getting, or if the slippage is getting worse, or if people start having neurologic deficits with numbness, tingling, or weakness in their legs or trouble walking. And it can be managed either by just decompression, and fusion with or without reduction of the deformity, meaning that you can either leave it as is and prevent it from getting worse, or you try and correct it so it looks straighter and better aligned. So in summary, the spinal disorders are very common. I tried to place more emphasis on things that you would see more often, which is the back pain, which affects up to 80% of the population at least once in their lifetime. I mentioned a few things about deformity. I didn't specify very much about neurologic deficits because they tend to be the most obvious things that require surgery, and I'll briefly talk about the surgical options next. Again, I highlighted the access to information that's available, and you just have to be very careful where you get that information from, and very few of these conditions require surgical intervention. So you have to always be open-minded about, even if somebody comes in with severe pain, it doesn't mean that they need to be rushed to surgery the same day or the next day. Very often with some patience and managing the symptoms, they can improve significantly and get on with their life without surgery. So next section of this talk is going to be on minimally invasive spinal surgery techniques. This is something that's becoming increasingly popular, especially because of potential reduction in tissue damage, blood loss, length of hospitalizations. There has been literature showing that there's earlier return to function. And most importantly, I think these days everybody's looking at insurance and the bundled payments, which are now part of the joint orthopedic surgery, but maybe may involve other specialties as well. So everybody's trying to minimize the cost, and the biggest, a big chunk of that cost is the hospitalization and length of stay, other than the implant cost. So if we can get patients moving faster and they have less pain and they can get back to work faster, the overall costs of surgical intervention can be reduced significantly. So this is a picture of somebody who had a minimally invasive surgery, and you can see instead of the typical one incision in the back, they have two incisions that are slightly off the midline, one on the left and one on the right. And when, I always tell my nurses and the clinical staff to always examine the patient. I think these days we've gotten away from it. And if you just look at the person's incisions, you have a fairly good idea of what might have been done to them. So always examine your patients and see where their scars are. This is a more traditional surgery. This would be a scoliosis operation. You can see how it's a big incision. You see a long rod, screws on the left and right. And this is a traditional surgery. It's been done for over almost 100 years now. Previously, we did not have any instrumentation, but this is some form of surgery that's been around for almost 100 years. There is significant soft tissue damage. You can see how the muscles are all stripped off the bones. As you can imagine, there can be significant blood loss with this as well, and this can cause pain and longer hospitalization and prolonged recovery. There's also MRI evidence that when you do this traditional surgery, the muscles are removed or peeled off the bone, and it ends up devascularizing them. So the muscles end up necrosing and scarring. And this is on an MRI. You can see the red circles highlight where the muscles should look black. You see those bright white signals suggesting a lot of scarring where the person had previous surgery. And the term for this has been coined as fusion disease. So the minimally invasive exposures are trying to do the same operation but with less muscle trauma. Sometimes you can get away with smaller incisions. It just involves doing the same thing slightly differently with a different visualization. So for an example, this is an MRI of somebody with spinal stenosis at multiple levels, at L1, 2, L2, 3, but most significantly at L4, 5, towards the bottom of the spine. And you could do this with a traditional laminectomy, which is a classic technique. It's been around for a long time, very successful, and still can be considered the gold standard for treating spinal stenosis. You can see how the spinous process has been removed on the left, and on the right you can see the laminectomy, where you can actually look straight down and see the dura, where the bone used to be. So that's a satisfactory decompression. This is what it would look like on a CT scan. The spinous process, which is in the back of the spine, has been removed and the canal has been opened up. And this would be the kind of incision that you might get after that kind of surgery. So you could do the same problem slightly differently. You could treat the same problem surgically in a slightly different way. Again, I don't know how many of you have been to inside the OR, but this is I think this can be very helpful to get a perspective of what the patient goes through when they're in surgery. You can see that to do a surgery of the spine through the back, the patient has to be in a prone position, and a lot of times patients wake up with swelling on their face, and their arms are aching, and their knees hurt, and their hips hurt, and you don't know why. This may be why. If the surgery took 5 hours and they're in this position for a while, they can get stiffness of their hip, the knee. If they have a shoulder issue, they may feel pain in the shoulder. Their face gets swollen, their belly can get swollen. There's a lot of dependent edema that happens. So this is a typical positioning for a spinal surgery patient. And this is looking at, you're actually looking inside the spine, and you're looking at the dura there, which is a white shiny object right in the middle of the cannula or the retractor. So you can have a very small incision, about an inch or so, and you can visualize it, what you need to do through something like that. So principles of minimally invasive surgery: performing the indicated procedure in a less tissue traumatic way. That's really always been the goal, is to try and make smaller incisions and minimize the trauma so that you save the patient the recovery process and the pain that they might feel postoperatively. You do have to do the complete procedure, meaning that you can't try and do something, and if you can't visualize it, you just stop the surgery. You really haven't helped the patient much if you haven't accomplished what you started out to do. And you can always use a traditional technique as a bailout option, meaning that, as I said, if you can't visualize what you need to visualize through a small incision, you can always close that up and make a bigger incision that you would have done otherwise. And you always have to explain to the patient beforehand that there's a choice A that you will plan to do, but if that doesn't work, there may be a choice B that we may have to do, and so that when the patient wakes up and they have 2 different incisions or 3 different incisions that they weren't expecting, at least you've warned them beforehand. And you have to address the pathology, meaning if there's a disc herniation or stenosis, you have to treat that problem. So I've tried to categorize the minimally invasive surgeries in the spine in 4 different boxes, and this is just to kind of help you think a little better about how, what kind of surgical options are possible. So the leftmost box is a percutaneous decompression. So this is essentially trying to do a discectomy or a spinal stenosis surgery through a small incision, and this is a very, very popular way of doing it these days. And I just showed you an example earlier with the small incision. The percutaneous stabilization, which is the next box, that is trying to stabilize an unstable spine, maybe in the setting of trauma or instability, and that's trying to put screws and rods through small incisions through the skin. The third is the percutaneous fusion, and I'll show an example of that later, where you're trying to do a TLIF or interbody fusion through an incision. So people get always confused about the screws and the fusion. One doesn't necessarily mean the other. Fusion is a biological process where you're trying to get one bone to essentially become 2 bones to become 1 bone by fusing together, and you can do that with or without screws. So the screws are essentially just helping to stabilize the spine while the fusion is occurring naturally in your body. And you could certainly do a fusion without the screws as well. So there are 2 independent things, and patients get confused, and nurses also get confused sometimes about the fusion aspect and the screws and the role of why we use screws. And the 4th category is miscellaneous, because there are other options like disc replacements, etc., that are coming along, and I'll talk about them later. So the types of minimally invasive surgery, I mentioned the decompression surgery. So this includes the cervical laminotomy, includes lumbar discectomy, lumbar laminectomy, and this would be a view. So it's not a bad view if you have decent retractors and you have enough experience. You can get to see what you need to see through a fairly small incision. This is a surgical stabilization. So I mentioned the percutaneous instrumentation. So if somebody comes with a fracture or trauma, you can put multiple screws through fairly small incisions, and this can be done very quickly. Here on the right next to the screws on the left image, you can see behind it is the C-arm. So intraoperative radiography becomes very, very important when you're trying to do these percutaneous instrumentation cases. On the right, you can see the screws that have been put in and the rods that are connecting the screws. The 3rd category I talked about was the percutaneous spinal fusion. So again, You can have instrumentation without fusion, you can have fusion without instrumentation, or you can have both. And here is the spinal fusion. There's a lot of acronyms that get thrown out in the charts, and again, they can be very confusing. And sometimes you just have to look them up, what it means. But the bottom line is that you're trying to get two bones to become one. That's the goal of fusion, and there's different ways of doing it. Acronym like MIS, which means minimally invasive spinal surgery, MAST, maximal access spinal technology. Again, different acronyms for something similar. TLIF is a transforaminal lumbar interbody fusion. These are these have become fairly popular recently. XLIF, DLIF, LIF, which essentially mean the same thing, trying to do an interbody fusion through a lateral approach, meaning going through the side of the patient instead of the back. You have axial lift, which is trying to go through the around the tailbone. You can do percutaneous facet fusions, thoracoscopic spinal surgery. So in the chest, you can do through like a laparoscopic procedure and do spinal surgery anteriorly. So there's different ways of doing this, but essentially the goal is that you're trying to fuse one bone to the other. And this image on the right, the X-ray, is showing you the percutaneous screws put in, and also the interbody cages between L4-5 and L5-S1. And this is an example of a TLIF procedure, and I'll explain the difference next. Miscellaneous category, there's things like vertebroplasty or kyphoplasty, which are done percutaneously. On the top right X-ray is an example of a kyphoplasty. And there are spinous process distraction techniques, which on the bottom left, you can see where the spinous process have been distracted to help with stenosis. So what are the limitations of trying to do something in a less invasive way? There is a learning curve. You know, people have been taught to do it in a standard way, and there is a long time for you to overcome that and learn a new technique. Most fellowship programs these days do emphasize minimally invasive surgery, so the younger surgeons are fairly comfortable doing it. Some of the older surgeons may have a harder time with it. And then analogy is doing the hips as well, hip replacement surgery. Most surgeons are comfortable doing a posterior approach, but in your setting you may have seen people starting to do more anterior hip replacement surgeries. And general surgeons have been doing it for a long time. They've gone away from doing laparotomies, making big incisions in the abdomen, and just doing everything laparoscopically. So there is a learning curve there. It potentially can be longer operative time because of the X-rays, et cetera, you might have to do during the case. But as you get comfortable with this and do it more often, the speeds end up being about the same as doing it open. There may be a higher potential for complications if you're not visualizing everything you need to see. But again, as you get better at it, this rate drops significantly. Failure of execution, meaning that you can't accomplish what you're trying to do. And then intraoperative imaging, which you're exposing everybody in the room to a fair amount of radiation if you're starting out. As you get better at it, and with more practice, you can cut down significantly the number of X-rays you actually get in the OR. This is the array of options available when somebody comes into your office for a spinal fusion. So it's not just somebody walks in the door and you say they need a spinal fusion, and then you book them for surgery, and they show up and they get their surgery. These are various options available to you, and you have to think and customize what you're offering each patient based on their pathology, their anatomy, if they're obese, they're not obese, their age, prior surgeries. So this algorithm, this list of options goes through your mind as a surgeon whenever you see a patient that needs spinal fusion surgery. And these are fairly self-descriptive. If you just understand what the terms mean, you can understand what kind of surgery is being done. Most of these are posterior, meaning through the back of the spine. And then the anterior would be through the front of the spine, which is being done less and less because you need an access surgeon, and it requires somebody else's schedule to correspond to yours. And in some institutions that may be challenging. Transforaminal lumbar interbody fusion, I'll talk to you about that next. And then the lateral interbody, which has also become very popular recently. So when we talk about the TLIF, this actually is another way of looking at the procedures here. This is looking from the top is the back of the patient, and the bottom is the front of the patient. The backbone you see here is the spinous process. In the front you can see the vertebral body. And these are the landmarks. The bone is usually the landmark and the guide for your procedure. So If you're trying to do a discectomy, you put your percutaneous retractor very close to the spinous process. If you're trying to do a posterior lumbar interbody fusion, you move it a little further away to 2 centimeters. If you're putting a pedicle screw, you move it further away, 3 centimeters. If you're doing a TLIF, you move it further away to 4 centimeters. And if you're doing a lateral, it's coming through the side, which at the bottom it says the LIF. So this is something, the anatomy is, you always go back to when you're doing surgeries. This is an example of a TLIF procedure with percutaneous screws, and you can see the retractors are on both sides. This would be the setup of the patient, and this is what we would be looking at. So again, you can see how fairly small these incisions are instead of a traditional bigger incision in the middle, and you're actually fighting less muscle when you're going through a slightly off-center incision like this. Here's the video now. Hopefully this plays well for all the participants. So here's an incision that's being made, and then a bovie cautery to get down to the fascia. This little guide wire is used to help you localize the bone, the facet in this case, and then you put these serial dilators to make the hole bigger. And then finally you put the retractor down, which is really going to be anchored for the rest of the case to the retractor attached to the table. You take everything else out now, and now you have a view of what you need to see to do the procedure. Here, this is an example. This is what we're looking at down there now is the facet, and you're trying to resect the facet to do the TLIF. So you're going to use osteotomes and a mallet to kind of just chisel away the bone. And this is all done during most of these spine surgeries. So you can, once you see something like this, you have a better appreciation of what the patient goes through and what their symptoms could be, what complications you could get afterwards. So these are just fragments of facet capsule and bone that you're removing to be able to get to the disc. So now you've exposed the joint, the facet. You can see the cartilage there. Now you're going to start removing that cartilage, and you can actually get good pieces of bone here during this procedure, and that's used as autografts. So you can use this, put this back in the patient as part of their spinal fusions. You don't have to throw this away. And usually this is not enough to do the whole fusion, and you mix this with some cadaver bone. So this is a slow, meticulous work. You're trying to remove the cartilage and the capsule and the facet and work around the nerves. And then you finally get to the disc, and you can see there's a knife that's being used to cut the disc. The disc can actually be very tough material and doesn't come out very easily. You have to actually incise it and then use different retractors to protect the nerve, and then just grab pieces of disc out, as you can see right there. And that's a retractor to protect the nerves while you're doing this procedure. And you keep using this is a curette you use to clean out the soft tissue in between the bones. This is all the cartilage that's the disc that's slowly coming out. And now you create a void there, or a space for where you're going to do the fusion. And so that was the cage that's being put in and the bone graft. And you can impact that in to put it in between the bones where you need it to go. And this is part of this is visualization. Then you have to always get an X-ray to confirm it at the end. And this is to put the screws afterwards. These guide wires help you put the pedicle screws after you've done the interbody fusion. And you can put the pedicle screw percutaneously. You take the retractor out, and you can see that whole procedure on one side has been done to a fairly small incision, and then you do the other side to put the screws on the other side. So you get bilateral screws. And this is to get a starting point for the screw. You put some bone graft in there to get the facets to fuse on that side, and then you put the screws, and you have an incision that's about an inch and a half long. So for a skinny person, this can be a fairly small incision. You can see how less trauma there can be associated with this procedure. So the next thing, so this is a very common technique and one of the most popular techniques for spinal fusion, which is a TLIF. It can be done in an open way or, as you saw, in a percutaneous way. The next fusion option I'd talk about would be the lateral interbody fusion, which is something that's becoming very popular recently. This would be the incision. So if somebody goes in for spine surgery and then they come out with an incision on their flank, you're some of you might be scratching your heads like, what happened to this person? And I'll show you what happened. It's a promising new technique. It was actually originated in Brazil with Dr. Pimenta. And the purpose was to try and put a bigger cage. You can see that through a small incision and through the small retractor, you can only, the size of the cage that you put in for the fusion is fairly small for the T-lift because you have to work around the nerves as well. So people have tried to get around that problem by going through the side where you're not directly visualizing the nerves or retracting the nerves, and you can put a much bigger cage in. And the bigger the cage, the bigger the openings, so that you can put more bone in, and the more chance that it would fuse and not fail. So you have a much larger fusion surface with the lateral fusions. You can correct deformity as well. So a lot of times this is being used not just for back pain, spondylolisthesis, or spinal stenosis, but also for scoliosis. You can get less blood loss, potentially a shorter hospital stay, and quicker return to function. The problem with this procedure is that there can be some risks with it, and very often people end up with some weakness of their hip flexors or psoas. It can be unnerving in the beginning, but it does go away in a week or two. Some people can get thigh numbness, which resolves in a couple of weeks, and people can also get anterior thigh pain, which may take a longer time to resolve. So, every new technique comes with its own pitfalls, and you have to try and choose the best technique for the right patient. And what are the overall complication rate? It can be up to 6%. You can get hernias. As you can see, there's a flank incision. You can get ileus. You're working around the bowels. You can get weakness of the quadriceps. And you can also get a vertebral body fracture because you're trying to put a big cage into the spine. And you can see the position now of the patient is on their side. So these patients will have different positional complaints when they wake up and they're in the recovery than the person who was on their stomach. This here is on the side, and you can see in this case, 2 incisions that were made. And this is the setup. We're looking at it. These are X-ray images intraoperatively. This patient already has had a fusion, as you can see on the right X-ray, with screws that you see at the bottom, and we had to go one level above. So without trying to touch the screws at the bottom, we had to go through the side and put these 3 vertical lines that you see on the image. Those are the markers of the cage, so you know that it's between the bone. And then we ended up putting a screw and a rod from the side, so we didn't have to go through the back at all in this patient. All right, so that's a brief introduction of the minimally invasive techniques. So here's another poll question. Is there a pain team or protocol for managing pain in your orthopedic patients? Choice A, we have a pain team and we successfully use it for managing pain. Choice B, we have pain protocols or order sets instead of the pain team. Choice C, we have pain protocols or order sets as well as a pain team. And choice D, we do not have a pain team or pain protocols / order sets.
Four percent of attendees said A, 47% of attendees said B, 30% of attendees said C, and 18% of attendees said D.
All right, so I think for the 18% of attendees that don't have a pain team or pain protocol, I think it's very important to reassess where you are and bring it up with your team, because there's been a lot of studies showing a multidisciplinary approach, and having standardized protocols can improve patient outcomes. And actually, I'll address this with the very last section of the talk today. Okay, another poll question. What rehab disciplines, PT, OT, physiatry, or rehab physicians assist in a spine patient recovery? Choice A, no rehab disciplines utilized. Choice B, utilize PT and or OT. And choice C, utilize PT, OT, and physiatry.
of attendees said A, 77% of attendees said B, and 20% of attendees said C.
All right, so hopefully we can get everybody onto choice B or C. It may be because of the outpatient setting potentially, or it could be that you're doing ambulatory surgery and patients don't really stay very much in-house to get the rehab. But certainly, again, going back to the multidisciplinary thing, treating a spine patient is a complex undertaking, and the more teams that are involved in the care, studies have shown certainly that there can be better outcomes, especially when you're managing them surgically. Addressing the spinal fractures in the elderly, again, this would be a topic in itself, but I'll briefly talk about it because this is something that we see very often as the population ages. The consequence of spinal fractures can be loss of function, pain, and disability, and you can see an example here on the X-ray how the vertebral body at the arrow on the left is collapsing on the right, and this is another X-ray and the MRI on the right corresponding to it, where you can see edema or the white stuff within the bone showing a sign of a fracture. Treatments include non-operative, bracing, and open surgical, which has traditionally been a larger surgery, and then more recent, less invasive options. Now, these are already almost 8+ years old. Vertebroplasty originally described in '85, and then kyphoplasty in 1998. These are still commonly utilized, though more recently there's been some controversy about their role. I personally feel that if you've maximized non-surgical treatment, these procedures can play a significant role, but there are certainly criteria that you need to follow, including trying bracing, pain medications, and activity modification before performing surgery. So this is an example of how on the left the vertebral body is collapsed and compressed. On the right you can see with the cement. You can see it because it has barium in it. You can see it on the X-ray. It's elevated. Now, you're never going to be able to get it back to the original height, as you can see in the bone above and below. That's what a normal bone should look like. But on the X-rays, you can see that there is some height restoration, and you can do that through a very tiny incision, 2 millimeters, and the patients go home the same day. Last couple of things, these will be fairly brief, but the basis for motion preservation. So I talked a lot about fusion and back pain. So the future really is to focus on how do we preserve the motion of the spine, and mobility and stability are two equal partners in a healthy spine. They go hand in hand. And we have to rethink the spine as the vertebral bodies and not the discs or the main shock absorbers. And the discs are actually where things are moving. So we have to try and preserve the motion of the disc. So requirements for the ideal motion preservation device, it needs to expand the viable treatment choices for patient, meaning that you need to broaden your perspective and give patients more options rather than either do nothing, take pain pills, or have a spinal fusion. Most people don't want to live with potentially a spinal fusion with some restriction in their mobility, and they want to live as normal a life as possible where they don't have any restrictions on their mobility. So we should try and restore deficiency in motion while also providing them stability. Instability can be a source of a lot of pain, so once you stabilize the spine, that can help with their symptoms. And it should allow for physiologic motion to take place, so it should be as natural as possible as it occurs in the spine. And it should also last. You can't have something that you replace and it wears out in a year and you have to go back and replace it. And lastly, it must be biocompatible, meaning that your body shouldn't react to it. This is one of the devices that people have used. It's sort of in and out of favor, but this gives you an idea of the principle where you provide something in between the spinous process, and it distracts the bones to provide relief of stenosis pain, and it can be fairly successful in the right patient. More recently, people have looked at disc replacements. The lumbar disc replacements were very popular a decade ago, but they had higher failure rates and complications, so most surgeons have gone away from that. But something very exciting recently has been the cervical disc replacements. Instead of ACDF, which is the anterior cervical discectomy and fusion. So on the left, you can see a traditional plate and screws for the ACDF. On the right, the disc replacement. And these are modeled after a knee replacement or a hip replacement, where we're trying to preserve the motion of the spine. And here you can see an X-ray on the left and the right, and I'm not sure if you can see it very clearly, but 2, 3, 4. So between the 4th and 5th vertebra in the body, in the neck, the bones have come close together. There's a posterior osteophyte here. So it moves above and below the spine, but it's fairly stiff at this level. And this patient actually had a disc herniation and spinal stenosis and arm and leg pain. And she came in asking for a disc replacement. So this is the procedure that was done. And you can see how the disc space on the left and the right, there is some motion. You can see it's collapsed in the back here, and on the flexion x-rays, it's opening up at the front. So it's doing its job where it's allowing the motion of the spine when you're bending forward and back. All right, so here's the next poll question. Does your clinical setting have specialty teams to focus on a specific subspecialty, such as joint replacement or spine? Choice A, we do not have specialty teams in my setting. Choice B, we have specialty teams and spine is one of the teams. Choice C, we have specialty teams but spine is not one of the teams. And D, don't know if we have specialty teams.
Nine percent of attendees said A, 60% of attendees said B, and 23% of attendees said C, and 8% of attendees said D.
All right, so the vast majority seem to have specialty teams, and I think this is really the wave of the future. I think more and more insurance companies, more and more government agencies like Medicare, Medicaid, they're going to start mandating that these complex surgeries be performed in a setting where there are specialists, and even in community settings, unless you're a high volume place, they're going to start trying to recommend that most of these procedures be done in a tertiary care or a setting that does a lot of cases where the higher the volume, the lower the risk of complications and risks to the patient. So going back to the disc replacement that we talked about and the ACBF, so more and more studies recently that are looking at it. This is from a study from China in 2013, and they compared the literature available, and they concluded that the anterior cervical discectomy infusion was associated with shorter blood loss, but everything else was superior equivalent with the disc replacement surgery. And people have looked at outcomes. So the goal of this is to protect the next level up. A lot of times people get surgery at one level and then their next level starts degenerating and they have to come back in 5-10 years and get another surgery. And the goal of preserving motion is hopefully will prevent adjacent segment degeneration. So you can see that the risk of reoperation after disc replacement is quite low, or much lower compared to the fusion operation. And at the same level, you can get risk of recurrent surgeries 5 out of 103 or 4.9% patient, and the same level with ACDF is 7.5, but it jumps up to 11.3% when you're doing the next level, and the disc replacement actually helps to protect that next level. And costs, you know, there's been studies comparing the cost of a disc replacement versus a disc fusion. You can see that when you look at the overall cost over the 4-year period of follow-up, especially when you don't have to go back and reoperate, the costs end up being lower for a disc replacement. They may be a little bit higher potentially in the beginning or equivalent, but the costs definitely start getting better as you look further out. Here are some other technologies that are currently being used, this would be an intraoperative CT that's becoming more popular, especially if you do a deformity surgery. You can get a much better visualization of the screws in the spine, and this is how it would look in the OR. It's sterilely draped, so you don't contaminate anything. Image-guided surgery certainly has been in and out, and it keeps improving, and it helps you navigate and target your pedicle screws and the instrumentation. And this is something that's also in and out of favor in knee replacement surgery and hip replacement surgeries as well. And this would be an intraoperative O-arm image, so you can see on the left the screws, so you can actually get a three-dimensional picture of where the screw is, and certainly get much safer outcomes if you use this. But as you can imagine, there's a cost with this, and also the risk of more radiation exposure, especially to the patient as well. The latest things out there are the robot-assisted surgery. So this is something you'll hear more and more of, robotic-assisted surgery, and it's a computerized system that links up with the image navigation and allows you to target and put your instrumentation in a better place. And this is something that's being used in brain surgery as well. So what's the future that we're looking at in spine surgery? Certainly different ways of doing the same procedure, like a lumbar facet replacement, lumbar facet arthroplasty, non-fusion techniques with biologics, trying to find something instead of titanium and stainless steel that we've been using, to use more biocompatible materials, like biologic materials. Annulus repair following discectomy, so that you don't get a recurrent herniation. Using glues for repairing a tear of the disc or annular tear or rupture. Growth factors to maybe regenerate a worn-out disc. And gene therapy for pain. On the right is courtesy of my partner, this is a discectomy performed on a 20-year-old patient. So you can see that all this disc material that was removed from the patient is gone forever, and this 20-year-old patient will never be able to regrow this on their own. But maybe with stem cell therapies and other technologies, we may be able to regrow this disc in that patient so that they don't have the consequences of less disc material and early disc degeneration and back pain for the rest of their life. So in summary, for this section, the surgical techniques continue to advance, and we have to choose the technology for the patient, but try not fit the patient for the technology. So you have to try and customize what you're doing to the patient, not what's available necessarily in your institution, though that certainly plays a big role. And cost is also a consideration. You want to make sure that going with the latest and greatest doesn't end up costing you 2 or 3 times as much as a simpler traditional technology would do. And bottom line, our outcomes improved. Our patients doing better. Do they have less pain? Do they go back to work faster? Do they have fewer risks and complications? And the very last thing, not since this is a nursing education, I wanted to highlight the role of nurses in all this. I think I've tried to emphasize the importance of education and trying to make sure that wherever you are in your community, go out to courses and conferences and maybe try and do more hands-on things where you can get your hands on the instrumentation that's used so you can experience what the patient is experiencing. And when you're taking care of these patients, when they ask you questions, you're better informed about what exactly happened, like how they were positioned in the OR or what kind of instrumentation was used or implants were used in their case, so that in case they feel something, you have a visualization of what's going on with them. So a colleague of mine in Seattle came up with a Seattle spine team approach to adult deformity surgery. And adult deformity surgery is one of the most complex surgeries you can do. There's a fairly high complication rate. There's a big expense with it, and there can be mortality and morbidity associated with doing these fairly long cases with multiple hours and a lot of bleeding, etc. So they tried to come up with protocols, and essentially they concluded that having 2 surgeons in the room, it seems intuitive, would help the surgery go faster. And this is not just a surgeon with a resident or a medical student. This is 2 fully qualified attending spinal surgeons, so that you minimize the risk to the patient and you expedite the case. There's a live preoperative screening conference that's done prior to the surgery, so that all the participants taking care of the patient have an opportunity to get a feel for the patient beforehand, voice their opinions and experiences, and if they have any specific concerns about the patient, that can be taken care of prior to surgery rather than afterwards. If you're anticipating a lot of blood loss, you have an intraoperative protocol for managing coagulopathy, and that's one of the risks of these adult deformity surgeries. So when you have this sort of setup, they were able to lower the complication rate to 16% from 52%. I mean, that's a fairly remarkable reduction in the complication rate. They were also able to reduce the risk of a patient coming back to the OR for some problem with implant or bleeding or something else, to 0.8% versus 12.5%. And they also significantly reduced their infection rate to 1.6% versus 7.5%. So again, having a team approach, a multidisciplinary approach, having specialists that work together can make a big difference. So essentially the two key points are discussion, the preoperative live conference involving surgeons, internists, rehab physicians, spine anesthesiologists, and nurses coordinating the patient class is very important. You need to have a discussion with everybody involved, and communication. So summary of the conference generated and sent to conference participants, so that you just don't talk about it, you actually get something in writing, so that at the end of the day, when the day of surgery comes, you all remember what you had discussed and what the pertinent points of that particular case were. So again, perspective. I like to think big picture. So this is an example of this is a photo of from courtesy NASA of Saturn from Cassini, the spacecraft that went past Saturn quite a few years ago, and they were able to capture something very interesting in this photo, and it's a pale blue dot. And some of you might recognize that phrase from Carl Sagan, but that pale blue dot is actually planet Earth. So we're this tiny little dot out there, and where I work is even a tinier dot on the planet Earth in Long Island. So we always have to think big picture and kind of not forget to use a cliche, but not forget the forest for the trees. And the roles of treatment are evolving from surgeon as being the captain of the ship, you may have heard that phrase before, as being in charge of everything, to having a more collaborative and a partnership role where every team member is crucially important. And that's where the education comes in. So you can't participate in care of the patient if you don't feel comfortable taking care of the patient. So you have to educate yourself and get yourself to a level where you feel comfortable handling these and have a voice in managing these patients. And this is a question that I get asked a lot. If I get a spinal fusion, will I be stiff? And here's your answer. This is a patient that had a percutaneous one-level fusion, and you can see that she really has not lost any motion at all and has a complete relief of pain. So thank you.
Thank you, Dr. Suratwala. That was a very interesting presentation. There are a couple of questions from our participants, so I'll get started. If a patient has a ruptured disc at 4-5 pressing onto the ganglia that's causing weakness and it's removed, but they still have a radiculitis, does this resolve, or is this something they will have to deal with? Neurontin helps, but is this something long-term?
So this is a very common scenario. People come in with herniated discs, and sometimes people like to try to manage it on their own. They drag it out for weeks or months. So the longer that ganglion has been compressed, potentially the patient may have symptoms for a longer time. When you decompress, and hopefully the decompression is adequate and satisfactory, and you've taken the pressure off the nerve, then ultimately the nerve really has to heal on its own. And you've provided the healing environment, and that healing process can take 6 months to a year for that nerve to repair itself. In some cases, if you're a diabetic, if you're a smoker, if you're older, there's less potential for that nerve to recover. But if you're younger and healthier, there's a much higher potential that you'll get complete recovery. So again, it has to be very individualized. If there's no residual compression, it can be a slow process, and it can take quite a few months for it to recover. And you just have to make sure there's no residual compression still on that nerve.
All right, thank you very much.
You can always try an epidural steroid injection transforaminally if it's still inflamed and causing a lot of symptoms. But I think most people would try and avoid any invasive treatments and just stick to medications and time and give it a chance to recover.
All right, very good. Thank you. What is your view on braces after surgery? We have one surgeon that uses braces and one that doesn't. This is confusing for patients and nurses, especially in our pre-op spine class.
Yes, so that's a very good question. And I think that's where a multidisciplinary approach and having a departmental discussion comes in handy. I personally have used both braces and not used braces. The goal, and again, it's different if you're using cervical spine versus lumbar spine and bracing in those areas. in the lumbar spine, the whole goal of the instrumentation was so that you don't have to use bracing. People who are old school, who've been trained the old way prior to implants, they just used to do the fusion, put bone graft in, and they did not have the technology of screws and rods that we do now, and they just close everything up and put patient in a cast or a brace. So the whole purpose of bracing is to stabilize the spine, to let the spine fuse. But if you're using the pedicle screws and rods and the instrumentation solid, then you really don't need the brace. Some of it may be for patient comfort. It does help patients mobilize better after surgery. Some people say, I feel better with the brace on, I don't have as much back pain. So you have to talk with the surgeon who used the brace and try and figure out why they use it. You have to talk with the surgeon who doesn't and figure out why they don't use it. I think each may be right in their own way, but I think it's best to have a departmental policy so that, as you said, it avoids confusion and miscommunication among patients and your staff. But I think my short answer would be that there's really no significant role for bracing these days in the lumbar spine. In the cervical spine, people will still use bracing somewhat because the screws are much smaller if you're doing a fusion. And if it's an active person and they're moving around, there is potential for failure of the screws. In the lumbar spine, the pedicle screws are much, much bigger and they're much stronger, so there's less chance of that failing. And obviously, if you're doing a disc replacement in the neck, you don't use a brace at all. You actually get them moving so that they don't get stiff.
All right, thank you. How long do you tell your patients recovery takes for fusion surgeries?
Recovery takes after fusion surgery?
Fusion surgeries, yes.
So, we had this, I went through the traditional versus minimally invasive, so it depends on what technique you use. But if you're using the minimally invasive technique and percutaneous technique, the recovery can be quite rapid, and people can return to a lot of their activities within 2 weeks or so. You have to bear in mind that if you're trying to do a fusion, you can't accelerate that fusion. It will still take 2 to 3 months for at least 6 weeks for the bone graft to start fusing, and it takes a solid year or so for the bone graft to fully incorporate. So you have to be cautious during that time. I think most of the limitations are usually from the patient's pain. If you have a traditional incision and a lot of muscle trauma, usually it's a 6-week process for recovery from that. But I've had a lot of motivated patients go back within 2 to 3 weeks. They just don't want to sit at home. Other people, they want to sit at home and stay home longer than 6 weeks. But I think for a traditional incision, I would say 6 weeks. For less invasive, anywhere from 2 to 6 weeks, you can get a return to function.
All right, thank you. Do you treat osteoporosis before surgery or using screws?
That's a very good question. I think it depends on the age of the patient and the severity of the osteoporosis. I think if you have the luxury of waiting, I usually recommend that you build up the patient's bone stock prior to surgery, because if you're trying to put a screw into a bone that's very soft, you're going to it's not going to hold very well, and there's a much higher risk of fracturing the pedicle or the vertebra. So if you have the opportunity, you can try and build up the bone strength quality. I think there's been a lot of medical advances in osteoporosis management these days with medications like Forteo, et cetera, and there are others coming down the pike that actually are anabolic. They actually build bone rather than prevent it from breaking down, like the bisphosphonates. So you can, if somebody's very osteoporotic, I would probably treat them prior to surgery with something to strengthen their bones. And once they've had that, then even if they really need the surgery, use the instrumentation. But there are certain instrumentations that you can use that are meant for osteoporotic bones as well. So you'd have to use slightly different screws. And then this would be a patient I would consider bracing after surgery.